Hello, this is Dr. Raymond Lamb from the University of British Columbia in Vancouver, Canada. It's my pleasure to welcome you to this presentation, Improving the Management of Depression Using Measurement-Based Care. It's actually the first of three presentations on how to incorporate measurement-based care into your clinical practice. First, here are my disclosures and sources of funding. And my up-to-date disclosures are always available on my website, drraymondlamb.ca. Here are the learning objectives for the presentation today. First, I'll describe the rationale and principles of measurement-based care. Then we'll talk about barriers and facilitators to using measurement-based care in your practice. And then I'm going to briefly describe the embed project on measurement-based care that we're conducting in Shanghai. Many of the resources that I'll talk about are available on our website, workingwithdepression.ca. Of course, depression is a serious medical condition in China as it is across the world. In China, the estimated 12-month prevalence rate is about 3%, which represents about 47 million people suffering from depression. It's also a very disabling condition, and it's estimated that over 9 million years are lived with disability, representing 7.3% of all medical causes of disability. There are also great economic costs to depression, and it's estimated that depression costs the economy over 130 billion RMB in lost productivity. And while there are many effective treatments for depression, we know that only 54 to 62% of patients actually improve after antidepressants or psychotherapy, which means that we must optimize treatment of depression in order to improve these treatment rates. One way to optimize treatment for depression is to use clinical practice guidelines. I've been fortunate to co-edit the depression guidelines created by the Canadian Network for Mood and Anxiety Treatments, CANMAT, that we published in 2016 in the Canadian Journal of Psychiatry. These clinical practice guidelines provide recommendations for clinicians to optimize their treatment of people with depression. We also have provided summaries of the guidelines along with a patient guide that explains to patients and to family members what treatments are available for depression. And all of our guidelines are available at our website, canmat.org. The CANMAT guidelines start by describing principles for clinical management to optimize treatment for patients. And this starts with a comprehensive assessment of the patient that leads to a diagnosis and differential diagnosis, working with the patient to provide education and self-management, and then developing a plan to offer and deliver evidence-based treatments. But another critical principle is to use measurement-based care to monitor outcomes. So what do we mean by measurement-based care? Of course, all medical care uses measurement-based care, because how would we treat hypertension without measuring blood pressure at every clinical visit? How would we treat diabetes without measuring blood glucose and hemoglobin A1C regularly throughout treatment? And yet, we think that we can treat psychiatric conditions like depression without measuring it. Well, for psychiatric conditions, we don't have measurements like blood pressure or lab tests like blood glucose. But we have the next best thing, which is validated rating scales that we can use to assess signs and symptoms of depression. So when we were talking about measurement-based care, we're really talking about routinely using validated scales that are integrated into our clinical care of patients. And we can use scales to measure symptoms, to measure side effects, functioning, and quality of life. But it's more than just using a scale once in clinical practice. We also need to discuss the scores with patients so they understand what the scales are representing. We also use the scores on the scales to make timely adjustments in medication doses or with psychotherapy. And importantly, we can use the scores to make timely changes in the treatments if the patients are not getting better. And so it's the regular use of scores on validated rating scales, a discussion with the patient, and using the scores in clinical decision making that is the core of measurement-based care. For depression, we have many scales that are validated for use in clinical care. And these scales can measure, as mentioned, symptoms, functioning, side effects, and quality of life. We also have clinician-rated scales like the Hamilton Depression Rating Scale or the Montgomery-Åsberg Depression Rating Scale. And we also have patient-rated scales or self-rated scales, including many of these scales described here. For research, we often use clinician-rated scales, but for busy clinical practice settings, we recommend the use of patient-rated scales for measurement-based care because they are much simpler to use. For example, the scales in red are the scales that we use in the Mood Disorders Center at the University of British Columbia. A good example of a patient-rated symptom scale is the PHQ-9, which is a very simple scale, easy for patients to complete, consisting of the 9 symptom criteria for depression in DSM-5. And the patient simply rates how often they've experienced those symptoms in the past 2 weeks on a score of 0 to 3 for each item. And so they total the scores with scores ranging from 0 to 27. And the score can indicate the severity of the depression. For this particular scale, usually scores of 10 or higher indicate clinically significant depression, although in China, even lower scores may be clinically significant. But by using this symptom scale on a regular basis during treatment, we can track to see how patients are improving or not during the course of their treatment. When we talk about the management of depression, we usually talk about the acute phase of treatment, the first 8 to 12 weeks of treatment, and then a maintenance phase of treatment, which lasts longer. The clinical question for the acute phase is, how do you get patients well? And the clinical question for the maintenance phase is, once they're well, how do you keep them well? And so we have different objectives for these phases. In the acute phase, the objectives include remission of symptoms and restoring functioning. And so that's where scales can help, because we can determine remission using a symptom scale like the PHQ-9. But because functioning is so important, we also should include a scale to measure functioning to make sure that that is improving along with symptoms. For the maintenance phase, the objectives are to return to full functioning and quality of life and preventing relapse and recurrence. And so that's where scales can be helpful as well, to ensure that functioning returns to normal, and also to monitor in case symptoms start returning for patients who might need further treatment during this maintenance phase. So scales can be useful for both acute treatment and for maintenance treatment of depression. Many studies have now shown that measurement-based care can improve treatment outcomes for patients with depression. For example, this excellent study was conducted in China by this group of investigators and published in the American Journal of Psychiatry. It was a randomized controlled trial of patients with depression treated in a hospital outpatient clinic. All patients were treated with open-label antidepressants, including paroxetine and mirtazapine, but the ratings of the patients were done by blinded raters. The measurement-based care in this study was very simple. They used a patient-rated scale, the Quick Inventory for Depressive Symptomatology scale, the QIDS-SR, and a simple side effect scale, the FIBSR, to measure side effects from the antidepressants every 2 weeks, and the scores were given back to the treating psychiatrists. In this study, they randomized 61 patients to measurement-based care over this 24-week period, compared to 59 patients who received standard care without measurement over the same 24-week period. And they looked at outcomes using standard depression rating scales. What this study showed was that even simple measurement-based care improved response and remission rates in people with depression. So when it came to clinical response, which was defined as more than 50% improvement in the Hamilton Depression Rating Scale, 87% of the measurement-based care group achieved clinical response, compared to 63% of the patients in usual care. When it came to clinical remission, the results were even more dramatic. And by remission, this was a score on the depression rating scale in the remission range after 24 weeks of treatment. And you can see that the measurement-based care group, 74% were in symptom remission, compared to only 29% in the usual care group. So again, even simple measurement-based care can greatly improve treatment outcomes in people with depression. We also conducted a recent systematic review and meta-analysis looking at all the randomized controlled trials of measurement-based care for the treatment of depression. We used standard systematic review and search criteria and identified 7 studies that examined measurement-based care versus usual care. In fact, several of these studies were conducted in China using various rating scales for measurement-based care and various treatment algorithms to define treatment for the patients. What we found in the meta-analysis was clear evidence in support of measurement-based care over usual care for the treatment of depression. So for example, in the 5 studies that looked at depression severity, we found a standardized mean difference in depression scores of 0.53 in favor of measurement-based care, which was statistically significant and also clinically significant. In terms of looking at remission rates, we again found that measurement-based care led to significantly higher remission rates after treatment, with an odds ratio of 1.83, again statistically significant as well as being clinically significant. So it does appear that measurement-based care can improve treatment of depression based on these systematic review and meta-analysis. So there are many advantages of measurement-based care for doctors, for patients, and for hospitals and healthcare systems. So for example, for doctors, it can actually save them time because they don't have to ask patients every symptom of depression. They can use the scale scores instead. The scales can also help with diagnostic assessment because it uses the symptom criteria for DSM-5 and also for treatment planning. We can use the scales for tracking outcome of any treatment, whether it's medication treatment or psychotherapy. And if several doctors are seeing the patient, it can actually help in terms of showing progress from one doctor to another when the patients are seeing different doctors at different visits. Measurement-based care can also help patients because using the scales educates them about the symptoms of depression and the side effects that might be associated with them. It also engages patients in their care and really helps them with some of the shared decision-making along with their doctors. And for hospitals, using scales and measurement-based care is important because you can use the data to look at quality control and quality assurance. You can examine data for research purposes and for determining best practices. And there may be economic benefits because patients are getting better and the clinicians are more efficient in terms of their care of the patient. So again, many advantages to measurement-based care for doctors, for patients, and for the healthcare system. Despite all the advantages of measurement-based care, we know that many hospitals in China and elsewhere in the world still don't use measurement-based care, in part because they don't know how to start using it, what scales to use, and how they might incorporate measurement-based care into busy clinical settings. That was the main reason why my colleague, Dr. Chen Jun from the Shanghai Mental Health Center and I initiated a research study that we call MBED, Enhanced Measurement-Based Care Effectiveness in Depression, to really implement measurement-based care in the mental health centers in Shanghai. We were particularly interested in identifying barriers and facilitators to implementing measurement-based care in Shanghai, as well as incorporating smartphones as technology enhancements to measurement-based care, and then to compare this enhanced measurement-based care to standard measurement-based care in Shanghai, and to use the lessons learned to scale up measurement-based care to other areas in China and internationally. In the first part of our study, we interviewed patients, doctors, and hospital administrators to really do a comprehensive analysis of some of the barriers and facilitators to implementing measurement-based care for depression in the mental health centers in Shanghai, and recently published this in BMC Psychiatry. What we found is that there were barriers to implementing measurement-based care in Shanghai. For example, hospitals worried about the costs of using measurement-based care and whether they might need to adapt their electronic medical record for these measurements. Doctors worried that it might take time to do measurement-based care and add to the workload in their busy clinical practices. Some were worried that they didn't have sufficient training to use measurement-based care, or that patients might lose trust in their doctor as the expert when they were completing symptom scales. The patients also worried that completing scales might take time away from seeing their doctor. They worried whether they might have problems reading or understanding the questions, or whether there might be problems with cognition that might interfere with understanding the questionnaires. But we are also very glad to see that there were many facilitators to bringing in measurement-based care to Shanghai. We heard there was a lot of enthusiasm among hospitals, with many champions who wanted to bring measurement-based care to their clinics. Of course, there are many validated scales that can be used in China, translated and validated in China. And the hospitals felt that this was really an anti-stigma approach to help patients understand their depression better. Similarly, many doctors were very enthusiastic and had positive attitudes about measurement-based care, believing that it would empower their patients to be more active in decision-making. And many of them wanted to have more training in measurement-based care. The patients as well thought it was a really good idea to use measurement-based care to improve their knowledge, to improve adherence to taking medications, and also to reduce the stigma of depression by helping their families to understand some of the symptoms of depression. And so we were very encouraged to see that the facilitators of MBC were there to bring measurement-based care to the mental health centers in Shanghai. And so, based on the situational analysis that we conducted, our MBED project developed a comprehensive plan to bring MBC into the mental health centers in Shanghai. This plan included features for doctors, including having a package of scales ready to use, including a monitoring form for the charts and electronic medical records, providing a simple medication algorithm to use for measurement-based care, and then conducting training in measurement-based care, including presentations like this one, so that doctors could understand how to use the scales in their clinical practice. We also developed features for patients, including patient information sheets, and then some technology enhancements using smartphones where patients could track their own moods using scales via WeChat. And I'll talk a bit more about that in a few minutes. We also provided features for hospitals, including training of clerks and the workforce, the staff in each mental health center, identifying champions to help bring measurement-based care into the clinic, and then providing expert consultation to problem solve any issues that arose from implementing measurement-based care. So this comprehensive plan is a simple but effective way to bring measurement-based care into busy clinical settings. As part of the training for doctors for measurement-based care, we published articles with practical recommendations for busy psychiatrists to use validated rating scales. We also published our meta-analysis to illustrate the clinical effectiveness of measurement-based care for people with depression. And these are available for free download. We hope to finish development of this program very soon and to be able to offer it to the mental health centers in China. So, to summarize, in this presentation, we've talked about how measurement-based care can improve treatment outcomes in patients with depression. and how simple solutions can overcome some of the barriers for hospitals, doctors, and patients to successfully implement measurement-based care in China. We've also talked about how we can use technology like smartphone apps and WeChat mini programs in order to support measurement-based care. In parts 2 and 3 in this series, we'll look at some of the validated scales more closely, and then look at some patient examples to illustrate how to use them for measurement-based care in the clinic. Thank you very much.